Hello, my name is Susan Blank, and I'm an endocrinologist who works with the Virginia Department of Health. Thank you for joining me for this learning session, which is part of the Virginia Healthy Hearts Initiative. Today, we're going to be talking about diabetes and cardiovascular disease, and specifically about how good diabetes control can help protect your heart and blood vessels. Let's get started. We're going to begin by discussing the basics of diabetes, then move on to discuss the importance of good blood sugar control and diabetes treatment, and then we'll finish up by discussing some additional ways that people with diabetes can protect their heart health. Diabetes is a large and growing problem. There are currently 40 million American adults with diabetes, which is 14% of the US adult population. And unfortunately, this 40 million is really just the tip of the iceberg. There are an additional 115 million American adults who have prediabetes. The majority of those people will go on to develop diabetes unless they make significant lifestyle changes. So if we take these both together, over half of the American adult population either has or is at very high risk for diabetes. If it is not well controlled, diabetes can have serious health complications. People with diabetes have double the risk of heart disease as people without diabetes. And diabetes is also a leading cause of blindness, kidney failure, and lower limb amputations. Now that you understand why diabetes is such a big problem, let's spend a few minutes discussing exactly what diabetes is. Diabetes is a disorder of glucose metabolism caused by a problem with the body's ability to either make or respond to insulin. And glucose is the main type of sugar that the body uses for energy. Insulin is a hormone that allows the body to utilize that glucose as energy. The official name of diabetes is diabetes mellitus. The first part of that, diabetes, comes from Greek for siphon or running through. And this is because people with uncontrolled diabetes get really thirsty and they pee a lot, so it's like the water is just running through them. The second part, mellitus, comes from the Latin for honey, and that is because people with uncontrolled diabetes have a lot of sugar in their urine, which makes it sweet. And in ancient times, fortunately way before I became a doctor, doctors tested for this by either tasting the urine to see if it was sweet or pouring it on the ground to see if it attracted insects. You can think of insulin as a key that unlocks the cell's ability to use glucose. The insulin circulates in the bloodstream. When it comes to a cell, it binds to a specific protein on the cell membrane called the insulin receptor. When those two are bound together, it allows a glucose channel to open up, and then the glucose, which has been circulating in the blood, can go into the cell where it can be used as energy. When things are working normally, when you eat a meal, the stomach and the rest of the digestive tract breaks down the food into its component parts, and the glucose shown here as these little yellow hexagons gets absorbed into the bloodstream. It travels through the bloodstream, and when it reaches the pancreas, it signals the pancreas to release insulin. Insulin is shown here in these little blue triangles. And that insulin allows the glucose to be taken up by skeletal muscles and the liver and tissues throughout the body to be used as energy, and removes it from the bloodstream so that the blood levels of glucose can remain normal. In people with type 1 diabetes, the problem is that their pancreas has entirely lost the ability to make insulin. This can happen for a few different reasons, but the most common is an autoimmune destruction of the beta cells in the pancreas, which are the specific cells that generally make insulin. So in this situation, when someone eats, the glucose is absorbed into the bloodstream, but there's no insulin around to allow the skeletal muscle and liver and other tissues to use that sugar as energy. So it just builds up in the bloodstream, leading to very high blood sugar levels, while the rest of the body essentially feels like it's starving because it can't access any of that sugar. In people with type 2 diabetes, the problem is insulin resistance, which means the body does not respond as well to insulin, and it takes more insulin to do the same job. So when someone with type 2 diabetes eats, the glucose is absorbed into the bloodstream. The pancreas releases insulin. In fact, it's usually releasing extra insulin because it takes extra insulin to do the same job to allow the sugar to be absorbed into the tissues and muscles of the body. Over time, the pancreas gets tired and starts to wear out. It can't produce as much insulin. Then you start to see blood sugars rising. And late in type 2 diabetes, the pancreas can get so tired and worn out that it's not making much insulin at all, and it can start to look more like type 1 diabetes. This chart looks at the differences between type 1 diabetes and type 2 diabetes. We'll start with type 1 diabetes. It affects around 2 million Americans, and it's due to an absolute lack of insulin production, which is usually caused by autoimmune destruction of the pancreatic beta cells. These are the cells in the pancreas that are responsible for making insulin. And the typical patient with type 1 diabetes is young and thin. This is the most common cause of diabetes in children and used to be called juvenile diabetes for this reason, but we know now that it can affect patients of any age and any weight. And the typical presentation for type 1 diabetes is pretty dramatic. People feel really thirsty, they're peeing all the time, they can be losing weight despite being really hungry and eating a lot, and they can also develop a really serious life-threatening complication called diabetic ketoacidosis. This causes nausea and vomiting and even loss of consciousness. And the treatment for type 1 diabetes is insulin because we want to replace the insulin that their bodies can't make on their own anymore. In contrast, type 2 diabetes affects 38 million Americans. It's much more common. The vast majority of people in the United States who have diabetes have type 2 diabetes, not type 1 diabetes. And it is caused by impaired insulin action due to insulin resistance. The typical patient with type 2 diabetes is middle-aged and overweight. This is because people get more insulin resistant as we get older and as we gain weight. However, we're seeing type 2 diabetes more frequently in young adults and children as a result of the obesity epidemic. Most people with type 2 diabetes don't have any symptoms at all, which can be a problem because it leads to delayed diagnosis. Around a quarter of people with type 2 diabetes don't even know they have it. And this is why screening is really important because that way diabetes can be picked up with a blood test. It's recommended that every adult over the age of 35 who is overweight get screened for diabetes every 3 years, and that screening be done more frequently in people who have risk factors or have a diagnosis of prediabetes. And as you can see here, there's a much wider array of treatments for type 2 diabetes. We usually start with diet and exercise, and for some people that can be enough by itself. For others, they can take oral medications. They're non-insulin injections like the new GLP-1 agonists, and some people will go on to need insulin for type 2 diabetes as well as type 1 diabetes. Regardless of what type of diabetes people have, it causes the same group of complications. And these fall into two main categories: macrovascular complications, which are due to damage in the large blood vessels in the body, and microvascular complications, which are due to damage of little tiny blood vessels in the body. In the macrovascular category, we see damage to the blood vessels in the brain, which can lead to stroke, damage to the blood vessels in the heart, which can lead to heart attacks and heart failure, and damage to the blood vessels in the extremities. This can lead to something called claudication, where people get severe pain in their legs when they walk. It can also lead to gangrene and non-healing ulcers, and is a leading cause of the need for lower limb amputation. On the microvascular side, we see damage to the little blood vessels in the eyes, which can lead to something called retinopathy, which is a leading cause of blindness. In the kidneys, it causes nephropathy, which is a leading cause of kidney failure and the need for dialysis. And then in the nerves, we can see diabetic neuropathy, which causes numbness and tingling and pain in the extremities, especially in the feet. And sometimes the numbness can get so severe that people can really injure themselves. They can put their foot in scalding bath water or step on a needle and not even realize it, which can lead to severe infections and also the need for lower limb amputations. Diabetes is diagnosed with blood tests, and there are a few different types of blood tests that we use. The first and most common is the hemoglobin A1C. This is a test that looks at the average blood sugar over a 2 to 3 month time period. The next is a fasting blood sugar. So this is a blood sugar that's checked after someone hasn't had anything to eat or drink other than water for an 8 to 12 hour time period. It's always a good idea if your doctor is getting blood work to ask if that blood work needs to be fasting. If it is, I recommend that you try to schedule the blood work first thing in the morning. That way you can stop eating after dinner and fast overnight instead of having to fast during the day. And the third test, which is done less frequently, is called the glucose tolerance test. This is when a blood sugar is checked after drinking a standardized sugary drink. And over here on the left, you can see how these blood tests are interpreted. For the hemoglobin A1C, normal is considered under 5.7%. It's considered pre-diabetes if it falls between 5.7 and 6.4%, and diabetes if it is 6.5% or above. For the fasting blood sugar, it's considered normal if it's 99 or below, pre-diabetes between 100 and 125, and diabetes if it's 126 or above. And for the glucose tolerance test, it's considered normal if it's 140 or below, pre-diabetes between 140 and 199, and diabetes if it's 200 or above. Now we're going to move on and talk about the importance of good blood sugar control. There are a couple large landmark diabetes studies which taught us the importance of good blood sugar control on reducing the risk of complications. And the first of these is the diabetes control and complication trial, which was done in people with type 1 diabetes. And this chart shows some of the results. It looks at the relative risk of some microvascular complications of diabetes at various hemoglobin A1C levels. So in the purple, you see retinopathy, which is damage to the eyes, and the red is nephropathy, which is kidney damage, and the gray is neuropathy, which is nerve damage, and then the yellow is microalbuminuria, which is another marker of kidney damage related to diabetes. And you see here that as the hemoglobin A1C level rises, as the blood sugars get higher, all of these complications rise, some of them more dramatically than others. And you can also see that the separation starts to occur right around a hemoglobin A1C of 7. And that is why the goal for most people with diabetes is to keep the hemoglobin A1C under 7 in order to minimize the risk of diabetes complications. There is another famous diabetes study, this time done in type 2 diabetes, called the UK Prospective Diabetes Study, or UK-PDS, and it again showed a large reduction in the risk of complications with lowering of the hemoglobin A1C. Specifically, it showed for each 1-point reduction in A1C, there was a 12% reduction in stroke, a 14% reduction in heart attacks, a 21% reduction in any diabetes-related complication or death, a 37% reduction in microvascular complications, so those are the eye, kidney, and nerve problems related to diabetes, and a 41% reduction in amputation or death from peripheral vascular disease. Together, these studies proved that good blood sugar control could significantly reduce the risk of cardiovascular disease and other complications of diabetes, and helped determine that the goal hemoglobin A1C for most people is to try to keep it under 7 to minimize the risk of complications. Now that you understand the importance of good blood sugar control, let's talk about how we can achieve it with diabetes treatment. The first step to achieving good blood sugar control is to monitor your blood sugars. That way you know if you're reaching your blood sugar targets or if you need to make adjustments. This starts with hemoglobin A1C testing. Hemoglobin A1C, as we've discussed, is a test that looks at your average blood sugar over a 2 to 3 month period. It's a blood test that's done at your doctor's office, and it should be done every 3 to 6 months in people with diabetes. For some people, this is enough, but for a lot of people, they'll need to do additional blood sugar monitoring between visits. This usually takes the form of a finger stick blood glucose. This is done using a meter that you can buy at any pharmacy. You prick your finger, get a little bit of blood, and the meter measures your blood sugar. This is great. It allows more frequent home monitoring of blood sugars. The one problem with it is that you're only getting one point in time with each blood sugar, and it's a bit of a pain to keep pricking your finger again and again, depending on how often you need to do it. So there's newer technology that's becoming more frequently used called a continuous glucose monitor. And this, you attach a sensor to your arm. The sensors last on the order of 2 weeks, and it measures your glucose continuously. And it's really helpful because you can see if it's going up, if it's going down, what the response is to certain kinds of meals or exercise. So it can be a useful additional tool for some people with diabetes. For type 1 diabetes, the treatment is insulin, and the goal is to try to mimic the insulin response of the pancreas, which turns out to be pretty complicated to do. For some people, this means taking multiple daily insulin injections. This can be done with a syringe and a vial, kind of in the traditional way, or there are now pens, which make it easier. You can just dial up the amount of insulin that you need. And most people with type 1 diabetes will need around 4 shots a day. They take 1 shot, which provides long-lasting insulin that gives them some insulin throughout the day, and then they would need to take an additional dose of insulin with each meal or snack. A lot of people with type 1 diabetes also use insulin pumps, which is a more automated way of doing things. There is an insulin reservoir that's included in the pump, and some tubing leads to a little cannula which resides under the skin and has to be changed every few days. This way, the pump can deliver some insulin to people with diabetes all the time, and then they can program in additional doses of insulin with their meals or snacks, all delivered through the tubing and the cannula. These are increasingly being integrated with continuous glucose monitors and becoming more and more automated. The goal is eventually to have something called an artificial pancreas, which would basically be a continuous glucose monitor and a pump that were integrated and automated so that they basically took care of all the insulin dosing on their own without much intervention or any intervention from the patient. There's also some really exciting research for type 1 diabetes with islet cell transplants and stem cell research and immunomodulation, which hopefully will lead to a cure for type 1 diabetes before too long. For people with type 2 diabetes, healthy lifestyle changes are first-line therapy, and for some people, lifestyle change alone is enough to adequately control their blood sugars. This starts with healthy eating, including minimizing added sugars, increasing fiber, which has been shown to reduce blood sugar spikes, and eating a diet high in whole, unprocessed foods, including vegetables, fruits, whole grains, beans, nuts, and lean meats. Exercise is also really important. Physical activity has been shown to improve insulin sensitivity, and a good goal is to try to get at least 150 minutes of moderate intensity physical activity a week. It's also been shown that exercising after meals, so something like a 15-minute walk after meals, can help reduce blood sugar spikes after eating. Weight loss is also important for people who are above their target weight. We know that excess weight can cause insulin resistance, and modest weight loss on the order of 5 to 10% can improve insulin resistance and lower hemoglobin A1C levels. And for a point of reference, 5 to 10% weight loss would be around 10 to 20 pounds for somebody who weighs 200 pounds. The majority of people with type 2 diabetes will end up needing a medication in addition to healthy lifestyle changes at some point. And fortunately, there are a lot of good options. As far as oral medications, first-line therapy for most people will be a medication called metformin. This is an older medicine. It's been around for a long time and has a good safety record. It's also quite affordable because it's available as a generic. But there are a lot of other oral options too, including sulfonylureas, thiazolidinediones, DPP-4 inhibitors, SGLT2 inhibitors, and the new GLP-1 agonist, which has become quite popular not just for diabetes treatment, but also for obesity and weight loss. They're non-insulin injectables, most notably, again, the GLP-1 agonist. And then some people with type 2 diabetes will end up needing to be on insulin. There's also a surgical treatment for diabetes, which is bariatric surgery, which includes things like gastric bypass surgery, which can be very helpful for people who have both obesity and type 2 diabetes. There are a number of treatments for diabetes that have been shown to reduce cardiovascular risk on top of improving diabetes control. These include GLP-1 agonists. Some examples of these include semaglutide, or Ozempic is the brand name for that, liraglutide with the brand name Victoza, dulaglutide, whose brand name is Trulicity, and tirzepatide, which goes by the brand name Mounjaro. The SGLT2 inhibitors have also been shown to reduce cardiovascular risk. Examples of this include empagliflozin, which is Jardiance, canagliflozin, which is Invokana, and dapagliflozin, which goes by the brand name of Farxiga. And then bariatric surgery has also been shown to be effective in reducing cardiovascular risk. I like to tell my patients that diabetes is a team sport. Obviously, the patient is the leader of the team, but it can also include a lot of other supporting players, including the primary care provider, an endocrinologist or diabetes specialist, and other types of specialists, including eye doctors, kidney doctors, podiatrists, and nutritionists. And a big part of that support team can also be a diabetes self-management education and support program. These are evidence-based programs that are designed to provide knowledge, skills, and support necessary for people to be able to effectively manage their diabetes. They're provided by specially trained diabetes care and education specialists. They require a referral from a healthcare provider, but are often covered by insurance. And there are a number of these programs available in Virginia, and you can find one near you by going to the VDH website. I've listed the website here along with a QR code that will take you there. We're going to finish up by talking about some other ways that people with diabetes can help protect their heart health. As we just discussed, for people with diabetes, controlling blood sugar can be a really important and helpful way to lower cardiovascular risk, but it's only one piece of the puzzle. We also need to think about and control other cardiovascular risk factors. That's why we tell people it's important to know and control your ABCs. Here, A stands for hemoglobin A1C, B stands for blood pressure, C stands for cholesterol, and S stands for smoking. And there are specific goals for each of these categories. So for hemoglobin A1C, the goal is to keep the hemoglobin A1C under 7 for most people. For blood pressure, for most people, the target will be a systolic or top number under 130 and a diastolic or bottom number under 80. For cholesterol, the goal is to keep the non-HDL cholesterol under 130. Sometimes this number is specifically listed on the blood test for cholesterol that you get at your doctor's office, which is called a lipid panel usually. But if not, you can calculate it by taking the total cholesterol and subtracting the HDL to get your number for that. And then for smoking, obviously the goal is not to smoke. So these are important numbers to talk to your doctor about so that you know what your numbers are and have a plan to hopefully get them to the goal. Unfortunately, right now, only around 15% of people with diabetes are meeting their ABC's treatment goals. This is a big problem, but it also provides a big opportunity for both individuals and communities to reduce cardiovascular risk and improve heart health. To finish, I want to zoom out for a couple minutes and talk about some ways you can help prevent diabetes-related cardiovascular disease in your community. The first is to lead by example. Get screened for diabetes. If you're diagnosed with diabetes, get diabetes self-management and education support, and work hard to control your blood sugars and other risk factors. If people see you taking your health seriously, they'll be more likely to do the same. The next is to share and educate. A lot of people don't fully understand the risks of diabetes, so talk to family and friends about the risks of uncontrolled diabetes and ways to improve cardiovascular risk. You can also help by organizing heart-healthy activities, things like diabetes screening events, diabetes education sessions, support groups, and cooking classes can help build healthy communities and lower the risk of diabetes and diabetes-related complications. And last but not least, advocate for change. You can help support policies that support diabetes treatment. These include things like expanded primary care access, which is really important to make sure that everybody has access to diabetes screening and treatment, and also policies that will help improve coverage and lower costs for some of the newer diabetes technologies, including continuous glucose monitoring and insulin pumps that makes diabetes management easier, and also some of the newer medications, including the GLP-1 agonists and SGLT2 inhibitors that have been shown to lower cardiovascular risk in diabetes. This concludes today's learning session. Thank you very much for your time and attention. I hope you've learned some helpful information about diabetes and cardiovascular disease. If you're interested in learning more about heart disease or diabetes, I have included the addresses for the VDH websites for both of those topics, along with QR codes that will take you there. Thank you and have a wonderful day.